Good morning everybody. It's my pleasure to introduce Aymeric Augeraud to you. It just reminded me that Aymeric has been a childhood friend of Charlie El-Koubi before Charlie worked at Augeraud, before he had a business of his own. As far as Aymeric and myself are concerned, we will go back. We'll go back to Garancière. So he graduated from Garancière. He's also a graduate of Saint-Louis University in Missouri for his orthodontics degree. When he came back from the States, we worked together again, but we never lost sight one of each other, and we worked again with Charlie when we worked together to develop the Genius system that you know and use. Is also the one who introduced this community to this simplified solution of the carrier system, and is going to talk about the carrier system this morning. No, not at all. No, I'm not going to talk about the carrier system this morning. It was just too long. Oh, okay. That's a problem when you have such a limited amount of time. Right, good morning. I'm delighted to meet you for those of you that haven't met before. Well, usually we never start on time. Well, you were in the room on the dot 4 minutes after 9, so congratulations. I suppose it also has to do with the fact that we didn't have a party yesterday, and so we didn't dance till 3 in the morning, so I guess it helped us get up this morning. So it's the first time we are going to talk about my topic today. It's been the 6th summit, if I'm not mistaken, 6th installment of a summit. I've always been a speaker, thanks to Charlie, and yet it's the first time that we talk about aligners, and I think it was high time. I think it's, again, the right time, because it's part of our daily practice at a more or larger scale. And there's a reason for that. It's because Clever Liner is really in the works and is about to be launched. I will discuss Clever Liner at the end of my presentation, but what I'm here to do today is to try to provide you with a review, an overview of what it's all about in matters of aligner today. Now, if we were to think about the beginning of the aligner technique, I think a wide majority of you is going to say, well, Invisalign, 1999, they created it. It was launched at the Chicago Congress. Now, there are competitors as well, but you're all going to talk about ClickCheck, mass production, algorithms and AI, when actually they only recently integrated AI, 3D scan, cone beam integration, but well, actually, it's not the case. Aligner treatment, or the inception of that treatment, dates back to Kessling in 1945. He used plasters, so wax and rubber to move teeth, and I'm sure that you all used a positioning or repositioning device. So the idea of using something but brackets has been around for a while, and when you think about the beginning of the end of the 19th century or beginning of the 20th century, a number of our colleagues have already thought about it. Naum in 1964 was the first one using thermoformed plastic. You're going to be surprised because align at the end of the day didn't invent anything per se. Biggerstaff 1970, setup and simulation on computers, and this is a feat because in 1970 computers, it was a black screen and green fonts. So, thinking about a setup on such computers is not a minor feat. Burston in 1979 already discussed staging and digitalized orthodontic treatment. So he was already discussing this. Ravi Nanda was his young teacher back in the 70s, and now Ravi Nanda is a master in the field of aligners. Romain talked about this yesterday, and so is very good with that. Sheridan, 1985, I'm sure that you are familiar with his stripping protocol. And Knott, 1988, is already discussing attachments. Of course, it was not industrialized form of attachments. They were more craftsman type of attachments. But again, Invisalign didn't invent anything. They just industrialized, they just brought it to the mass production stage. Now, for your information, this is Dr. Kessling, Pete Kessling. That was back at the beginning of the year 2000. He was already retired, but he was a teacher at my school in Saint-Louis, where I studied orthodontics, and the faculty of Saint-Louis is on the right-hand side of that slide. Today in the aligner world, there are different sorts of aligner companies, either B2B, so aligner company selling to the orthodontist, and then you have B2C, I'm about to say, unfortunately, a business selling directly to a client. And this is going to take many market shares, especially in large cities, for example, Paris. So in B&B, we have the Americans, Invisalign and Spark. We have the Chinese company, Angela Ines. They're going to come in strong before the end of the year, and they're good. Let me tell you that. We have the Germans of ClearCorrect and Orthocaps. We have the French company Smilers, Aligner Français, and potentially others. And we also have those companies that can give us, well, rather sell us softwares for in-office printing, Onisaf and Delphus. And Cleverliner, going forward, is going to be a hyper-hybrid solution. We conducted a reflection on what we want and how we can implement what we want and need as orthodontists. Now, in B2C, I didn't put the logos here, but you have Impress to Smile, Dr. Smile, Jouvence, Smile Direct Club, to name but a few. So thousands of patients without a bonded retention, and so thousands of them that are bound to come back to our practice in a few years. Now, I've tried on this slide to place a review of benefits and drawbacks from the orthodontist point of view. So as far as the benefits is concerned, I heard modern, easy to use, interesting, helps to boost the patient base because you can treat more adults, and it gives a more more modern and fashionable aspect to your practice. Predictability, this I'm not sure about. Optimization of your agenda. Well, of course, yes, you have less emergencies, less appointments, and less fatigue, something I agree with. And of course, a possibility to treat in an invisible way complex malocclusions. This, of course, only for very experienced orthodontists when they use premium brands of aligners. Drawbacks, patient compliance, biomechanical limitations of aligner. As an aside, I just want to state that bracket and wires also have biomechanical limitations. We all have limits. Less assistant, more work in the background. The work in the background is when you work on your computer in the evening, just working on a clean check. So, comes back to that. Cost of your aligners being purchased from Spark or Invisalign, and the generalized use of AI. Now, Invisalign is boasting the fact that they use AI. Yes, but their AI is fed by data of all orthodontists and general practitioners working on cases. Do you really feel like using an AI which is nothing but the average of the 18 million patients treated with Invisalign all over the world? Not necessarily, because your objectives are maybe different. Maybe you do not have the same way of working as the average orthodontist in the world, and that's an issue. Their clean check is not too bad, it's not what I'm saying, but that's something that you need to take into consideration. And also the last drawback is the fact that you become dependent of the production sites of your manufacturing of choice. Now, about the advantages, the possibility to treat complex malocclusions, and I'm going to start with a case because I know this is what you are eagerly waiting for. This patient, step by step, but not too comprehensively because we don't have much time. You do see that this patient benefited from a surgical treatment. You see that we do have the maxillary incisor protrusion. We're going to show you how we treated this patient. So that's the young man. If we were to summarize a reclinatic mandible, this is the dental occlusion class 2. 46 and 36 were extracted. We have a divergence of the skeletal bases, and we do have narrow arches, upper and lower arch are narrow and tapered. You can see on the left hand side that you do have this very narrow arch. Is very narrow, very tapered and quite long. Now this is the side teleradiograph where you see the maxillary protrusion. You do see that the chin is retreated. This is a pan X-ray. Not too much more that we can tell about this. Now the first step was to do a disjunction of the upper arch. We did that with Dominique Defresne. We didn't go for a disjunction device that would be supported by TARDs, which can be of course very nice to use when you treat a patient with aligners. For financial reasons, we used a maxillary band supported disjunction device, and we created that space. So nothing special to mention here. We removed the disjunction device to scan the patient again, and then I had him wear the disjunction device while we were waiting for the aligners to be delivered. Now, what I'm really looking for is to have that overjet. This overjet is going to help coordinate both arches, and the fact that the upper arch is now more wide has created spaces, and it's going to help me correct the incisor protrusion. Now, as Bilal said, this was my treatment plan. I'm not saying that it is the ideal treatment plan, may not be your treatment plan, but that was mine, and I had the result that I'm about to show you. There was a pre-surgical preparation. So after we had the disjunction phase, we had a pre-surgery phase. 8 months of aligner wear, 32 stages, so we coordinated the arches, we reduced the incisor protrusion, we helped also with the incisor protrusion in the lower arch. We opened a space of 10.5 millimeter before implant placement inside 36 and 46, and then we aligned, leveled, and this was the objective of those first 8 months of treatment. Now let me show you this clean check. So this is a stage which comes before surgery. So before we then go for a mandibular advancement. So we create space in the molars. We do see that there's some mandibular, the mandible is retruded slightly. Actually, there are not 32 stages, but 48 stages. My mistake, says the speaker. And so we had the patient change his aligners every week. So I'm sorry, there's a mistake in my presentation. Not 32 stages, but 48 stages. 48 weeks is 10.5 months. Now, the patient is ready, and then you see the jump. Oh, maybe we're not going to see the jump on that clean check, but it doesn't matter. So, now we've reached the end of the pre-surgical phase. So the arches have a very nice shape. We have open spaces for implants. You do see that overjet on the side, which is really going to help the mandible fit underneath the maxilla. So implants are ready to be placed, or rather the space is available for implants. This is a side teleradiograph. We reduced in a rather significant way the maxillary incisor protrusion. Of course, the mandible is still very retrognathid. So before surgery, we bonded ceramic buttons on all posterior teeth. Dominique Defresne did the surgery, so mandibular advancement with sagittal split, and elastics were worn after surgery. That's the result after surgery. So this is when this patient came back 1 month after surgery. So, to be honest, we could have stopped there. It's really because we have this molar and premolar underbite here, which we continued. Maybe it could have settled by itself, but you do see those buttons, so those buttons helped in the elastic wear. But we decided, as I said, to go for a shorter finishing stage, 4 months, during which aligners were changed every 10 days just to settle that bite in the posterior segment. This is the other side. There we go, so the patient before, patient after. So the maxilla is undeniably larger. We gave that patient a very nice arch shape. Lateral view, we do have a very nice occlusion, functional occlusion, and for those eagle eyes of you, the molar was better derotated before surgery than now, but that's what it is, and before and after. So if I were to summarize today, it is possible to treat a case like this one without extraction, with surgery and aligners, which is not too bad, you will grant me this, which means that we've reached a level. Of course, we needed buttons and elastics, but we managed today to treat cases like those. Now, amongst the drawbacks of aligner treatment, the lack of compliance. This is the main issue that you all mentioned. Of course, you need to select your patient properly, but it's difficult. They all pretend that, yes, I'm going to be compliant, and sometimes, you don't have the right patient. Then you have those blue markers, they don't work, for Invisalign, they were indicators. You can also use dental monitoring or virtual monitoring. Up to you. It's really not up my alley. It's not something that I like doing because it's too much added work. Also, you need to motivate your patients. And here, I'm just going to give you my own tip. Adults and children alike, I never ask them, you've worn your aligners 24/7, did you? And actually, I don't ask this that way. I ask them, well, please tell me when you forgot to use your aligners. And then the truth is coming out. Oh, yes, I didn't wear it because my sister got married. Oh, I forgot to wear it a couple of nights this week. Or, yes, I never wear them in the afternoon because I can't brush my teeth. So you have a real answer if you use that kind of question. So it's very important. And of course, you need to really insist on cooperation. You should not be the only one shouldering the responsibility. It's impossible to order 4 or 5 finishing stages, 4 or 5 sets of finishing aligners. It has to be clear from the onset, because if not, your practice is going to shoulder all this, and it's not profitable. Price is key. The higher the price, usually, the better the patient's compliance, because the patient is going to invest a lot of money, and usually they're going to be more committed. Also, in your terms and conditions, legally, you have the right to integrate paying finishings. So some finishings, you have 2 free of charge finishing set of aligners in the light version of Invisalign, but if you were to order the 3rd set of finishing aligners, this will come with a fee. Same goes for comprehensive solutions. After 4 or 5 sets of finishing aligners, if I were you, I would have them pay for any extra set. But this is just the way I go about this. Now, biomechanical limitations, where we have a hard time. Well, in case of impacted teeth, extrusion of a single anterior tooth, closing of a space, correction of severe retruded teeth, or correction of severe deep bite. There may be more, those are my personal limitations. Now, with the Genius system, you have no problem dealing with those malocclusions, but you have those limitations. You have biomechanical solutions. With Invisalign, you have power ridges, butt ramps, optimized attachments. They don't work that well, if you want my opinion. You also have intermaxillary elastics, you have power chain, etc. Now, again, all this works rather nicely, but you need your patient to be compliant because, of course, the patient needs to be wearing the elastics 22 hours per day, so it's not only night wear. So for impacted teeth, that's what you do. You also know this treatment option, what we call bootstrapping. Bootstrapping works sometimes, not always. So extruding a lateral tooth becomes difficult when it's actually not that difficult with bracket and wires, and that's a shame because they're right in the middle and at the front. Now I'm going to exemplify with this ectopic canine. Again, I'm going to move swiftly on diagnosis. So first I'm going to distalize. I'm going to have this reciprocal movement. I'm using elastics on the right eye side as well. I want to create enough room for this number 1, 3. As soon as I have enough room on mesial side and distal side, I'm going to have a patient wear elastics in a V shape, 44 up to 1-3 down to 4-3, and the attachment is only here to help maintain the extrusion that I got at night, to maintain that extrusion during the day. And again, I get that canine in the arch once there's enough room. If you don't do that, you have too much friction, it's going to take forever. So that's the other side. The other side is more conventional, I would say. So you do have rotated canines, you do have a lateral open bite, so there are a number of malocclusions. But again, I wanted to show you what you can do for canine treatment and how I compensated for the biomechanical limitations of Invisalign. This is the occlusal view. So very clearly you see that there's not enough room for that canine. So I start by creating enough room. And once again, this is my treatment plan. Maybe some of you would rather go for extraction. That's fine with me. Everybody just is the master of their own practice. I had those lingual attachments because the patient just didn't want to hear from buccal attachments. So that's what it was. And with this occlusal view, you do see on the lower arch that those canines had pretty severe rotations. Now, look at that stripping protocol. I only do stripping when contact points are available. I usually limit to 0.2 on the anterior, 0.5 on the posterior, 0.4, I'm sorry, on the posteriors. Now, 18 months of treatment with elastics 1 at 9. The initial set of aligners 60. So 13 months. This is a very horrible picture. Gingiva is very inflamed, yellowy teeth, looks terrible. Anyway, this is by no means perfect, but this is at the end of the first phase. Of course, we wanted to improve that occlusion. We had the first set of finishing 3 months and the second set of finishing 2 months. And I was expecting that because the case was rather complex. Now, this is a final solution. Decent. Decent also from a periodontal point of view, because we had a severe periodontal case here, and now this patient will need a graft. This is what I do. Well, actually, this is what my periodontologist colleague recommended, that I finished the ortho treatment before the patient went for a graft. Easier on the left-hand side than on the right-hand side. This is the upper arch. Now you see that we have that bonded retention with 1-3 and 1-4. I think it's imperative here because we need that very strong retention on 1-3. It's not a child, and we may have a relapse if we don't have that. Same goes for the lower arch. You know that the canine lines were very rotated, so I decided to bend the wire and include 34 and 44. I always tell my patients that after a few years, well, hopefully not a few months, after a few years, the wire may unbond or break. And if this is the case, I will not rebond and I will forgo the retention. So this is this patient 17 months after I debonded, so he's stable. Well, 17 months later, he's still stable. Now, I'm not going to show you a clinical case, but there are also solutions to close extraction spaces when there's a missing tooth or after extraction, and this helps get a decent root parallelism. There's an attachment named Power Arm in Invisalign. It's not in the database, but you can ask that to your technician, and it helps you get this with reciprocal movement. Now, the Power Arm is really not going to transfer your movement to the resistance center, and for that reason you'll have some buccal movement. It's not perfect. Now, when you want to correct a severe incisor retroclination, I'm currently treating a patient like that with elastics. So you have TADs, you also have a moment that you get from the TADs going down to the palatal side, and this is something that you have a hard time correcting with aligners only. Now I'm going to talk about severe deep bite. You have those dogs here and there. You also can watch conferences on deep bites, and all those colleagues say, well, my theme is deep bites. But the deep bites that they show are not very severe, so it may come as an exaggeration. So what can we do with aligners and deep bites? There are cases that are almost contraindication. I'm about to talk about this. Now, a study demonstrated that on average, the deep bite correction that you actually get, is only 40% of what you see on the clean check. And the more severe the supraocclusion, the less correction you're going to have. So for example, if on clean check you have 5 millimeters, you're going to have 2 millimeters in real life, 1.5. So conclusions therefore are the conclusions are the following. So first you have favorable cases. Well, those are those cases, we all learned that in school, is when you need to also procline your incisors. So what are we going to use? Bite rounds. We're going to have a hyper extrusion on the posterior teeth. You're going to have those red contact points, and on your clean check you're going to ask for a hyper correction of your deep bite. This is a favorable case. It's an easy case. When you want to correct that deep bite, so this is what we call a more alveolar type of deep bite, so it's not easy to correct, and that patient needs some proclination. So those are those red contact points that you want to get on your clean check at the end of treatment. Works rather nicely. When you have those red contact points, you very rarely have a posterior open bite. So this is corrected 0.5 millimeter corrected deep bite. And this is what the clean check looks like. When I ask for power ridges, I always include attachments on the laterals. You do not need power ridges on the laterals. The dog that you need doesn't require power ridges. And also, when you have 4 power ridges on the laterals and on the centrals, it's not going to help with aligner fitting properly on the teeth. So I only ask for power ridges on those 2 centrals. Okay, 5 minutes left. Now, the proclination of those incisors is going to help with deep bite correction. And the same goes on the lower arch. Now, this case is simple, even too simple. I like showing complex cases, those cases where I have a hard time finishing my cases. I think it's more interesting. Now, a lot of proclination. I mean, some of you are going to be afraid by now. Now, this is the case before and after. And then again, it's not really because I'm a good orthodontist, it's just because it's a highly favorable case. And very rare, I didn't have to order any finishing sets, any finishing aligners. This is the treatment plan. On the right hand side, you see the date when I opened that case, 22nd of June. We did one clean check and we didn't ask for any refinement. So all went well. Easy case. Now, there are less favorable cases, but you really have to define when you start with. I'm not saying that you can't treat those patients. Maybe you're going to need TARDs, but when you have a very severe spay curve, then you need to intrude the incisors. You can do that with TARDs. I like using TARDs. This is one of the options. Now, when you have a gummy smile, unfortunately, I do not have a gummy smile example in my patient base that I could show you. So this is from a book, but this is exactly what I do. An elastic from the palatal side going up to the studs on the buccal side, and it's really going to help. I'm not saying that it's impossible to treat. I'm just saying that you need more experience, and you need, of course, to have a super motivated patient with a gummy smile, because we're going to with aligners, hooks, aligners, and also TARs, etc. So, you know, the whole shebang. And those cases that are very defavorable is when you have a loss of vertical dimension. So because the skull bases are converging, bruxism, where posterior teeth that are absent, or posterior implants, that's very difficult. You need to be lucky. You need to have a compliant patient. You need all the stars to be aligned for those cases. Also, when you have a deep bite, but when you can't really procline those incisors, and when you need this palatal root tool, those cases are more difficult. Very quickly, this is an ongoing case, not finished yet. This patient, this lady, missing teeth, loss of vertical dimension, she has bruxism, you know, she ticks all the boxes, but she wanted treatment. This is a simple case with genius, but you know, nowadays in Paris, an adult patient, they don't want bracket and wires. Sometimes they do, but it's really the exception. All of them want aligners. Now you see that the skeletal bases are pretty much convergent, and so the biomechanical solutions in those less favorable cases is to try and increase the vertical dimension on the posterior segment. So if you have a very good general practitioner or prosthodontist, they are very good. They're going to implant, they're going to recreate a vertical dimension, but you really need to have the right team with you. The problem with her is that she lost dental tissue, and we need to rebuild that. Now, what you need is try to compensate for the loss of vertical dimension. So what can you do? In that case, the particular patient, we bonded bite turbos, composite bite turbos, and hardware wear posterior elastics. Now, I read many papers where they say that with Invisalign it's impossible to extrude teeth because the aligners prevent those teeth to extrude properly. Well, it's true compared to bracket and wires. However, you can open the occlusal plane slightly, and it's going to help. Of course, you try to have a bite limited to 0 millimeter. It's a borderline open bite, and you also have to tell your patient that it's going to be very long. This is a terrible case. I know I'm going to have this patient in my chair for the next 2 years. So this is the clean check of that patient, and I'm going to show you where we are. Now, this is a zero a deep bite or open bite, borderline. Now, she's finished the first set of aligners, and the patient asked me to stop treatment. Now, I should have ordered a couple of sets of refinement, but this is what we got with that clean check. 43 aligners with weekly change, so 1.5 year treatment, composite bite turbos, and posterior elastics. So the result is not perfect, far from it. And I know that I'm in for a hard time. She's going to have a bonded retention, but if it breaks, she will need a Vivera retainer. Never mind. So, complex cases, you need to use lots of auxiliary devices. So it really depends on the orthodontist, how they trained, how they understand biomechanical principles. Also, they have to be ready, those orthodontists, to continue their training. There are plenty of conferences out there. Kenji Ojima, we know that there's a lot of talking in his conferences, but it's interesting to listen to what he has to say. And also, you need to be experienced. And when I say experience, it's a number of years you've been an orthodontist, but also the number of cases that you've treated with aligners. Also, the quality of the softwares, the quality of AI is important. You shouldn't get yourself be discouraged. I think the future is really in those two last bullet points. I think that we reached a sort of technical plateau, but things are going to change very quickly. So what's to come? What are our prospects? The objective is to push the limits, and now it's the time for me to talk about Cleve Aligner. Cleve Aligner is a principle which is going to use a true artificial intelligence and not an algorithm. There's a difference in between both for those who know. So the orthodontist is to be the master of his or her data set. You're going to have a personalized set of data in the cloud, which is going to be limited to your practice. So that's very interesting. You're not going to have the data of other orthodontists, but only of your cases. So you're not going to use the data of the Indian orthodontist working in Mumbai or the orthodontist working in Kenya. I have nothing against them, but my patients are maybe different from his or hers, and I don't want to generalize or have an AI which takes into consideration very different conditions altogether. So AI is going to work on staging, on the final result. So it's not only on the final picture, only on the equivalent of clean check. It's going to be a very comprehensive use of AI. We're also going to provide printing in office with the advantages that we're going to control our costs, we're going to control the deadlines and the time that you need. The extreme case would be that you have your patient in the chair, you're going to work for 1 hour on that case. When I say 1 hour, it's not 1 hour on the computer. In fact, I think you're going to spend 10 to 15 minutes on the case, and then the computer is doing what it has to do. And after 1 hour, you can print those aligners. So the extreme case would be your patient comes in the morning, you work at lunchtime, and in the evening, the patient can come back and get his or her aligners. We're going to compensate for some biomechanical issues. Of course, according to me, we need to publish more, we need to communicate more on our biomechanical limitations. There are a lot less papers out there on aligner treatment. Now, you can find tons of videos or trainings online, probably more than what you find in literature. And also the advantage that we have is the material. We're going to use graphy, for example, to print in 3D or 4D in office. And I think that the new type of plastics that we're going to have is going to help us have attachment-free aligners. If you are fortunate and can listen to Ravinanda, this is what he's talking about. This is his forecast for future aligners. Then it will compensate, for example, for the lateral extrusion. It will help with that, for example. So I just wanted to show you the workflow of a treatment today in a practice, and this is what happens today on the left, and on the right what we'll have tomorrow with cleft aligner. There are a number of steps that are going to be removed because they're going to be replaced by AI. So the baby is not born yet, but he's grown very nicely in his mommy's tummy, and so we would like to introduce you to that baby as soon as possible. This is my list of references for those of you who'd like to have my references, and I'm done. Thank you ever so much.